Good morning. Good morning again to all of you. I hope you enjoyed the first session. It was very alive, very strong and full of new information. We are now going into a more clinical session. Well, let me first introduce myself. I'm Stefano Guandalini. I founded this Celiac Center at the University of Chicago about 20 years ago. And I'm very proud of all the achievements and the progress we have been making so far. So the session is mostly a clinical one, and I want to start by thanking our sponsors, Brooke and Duncan McLean, as well as Karen and Eric Simon. Thank you very much. This is highly appreciated. The session is populated by clinicians, physician scientists, I should say, that are all friends of mine. Well, not all, you mean, long-time friends. They are pretty young. Everybody's young at heart. We'll start the session with Dr. Sonia Kapfer. She's assistant professor of medicine, the Department of Medicine, the Division of Gastroenterology, co-director of the Comprehensive Cancer Risk and Prevention Clinic. And for this specific theme today, she's a director of clinical genetic research at the University of Chicago Celiac Disease Center. Her topic will be HLA predisposition in celiac disease and autoimmune disorders. Sonia, the stage is yours.
Thank you so much, Dr. Guandalini, and I would like to also thank the organizers, Dr. Jabri, Dr. Verma, the conference supporters, and of course, our patients who continue to inspire and motivate us to do better and always clinically relevant research. So my topic today is talking about HLA predisposition in celiac disease and autoimmune disorders, and we've already heard this word HLA being thrown around in the first session. So I'm going to dig down and talk a little bit more about HLA and then tie it back to celiac disease. I have no disclosures. So as a physician who cares for celiac disease, and certainly as many patients who may be on this in this conference can tell you, celiac disease often coexists with other autoimmune disorders, especially type 1 diabetes and autoimmune thyroid disease. And if we think about what are the commonalities between these seemingly different diseases, really, much of it comes down to this HLA and the human leukocyte antigen. And I'm going to be talking specifically about this molecule. So the key points for my talk over the next 20 minutes is to give you an overview of HLA and how it differentiates self from non-self. This is not a basic science talk, so I'm going to take it more on the clinical level. I'm going to talk about how HLA plays a central role in autoimmunity, and then finally end with how we use HLA in celiac disease management, specifically in determining susceptibility. So the role of HLA is really to present antigens, which are essentially proteins from inside a cell, to the immune system and specifically to T cells. So you can see here in this cartoon, we have a waiter presenting the antigen to the immune system. And if an invader or something that is not a threat to the cells is determined, an immune response is mounted. And so in this process also, finally, antibodies are produced between in a communication between the T cells and the B cells. And you may also be aware of HLA if you've ever had anything to do with organ transplantation, and it's also playing an increasing role in our understanding of cancer. So as we are very acutely aware right now during a global pandemic, microorganisms, viruses, bacteria, and fungi have been among the greatest threats to human existence. And Dr. Barrero showed us how changes in vaccines, antibiotics, and also hygiene have really been a game changer, so to speak, in our longevity. And these have increased quality of life and, of course, lifespan. So let's get more specific about HLA. So HLA, these are these proteins that are found on particular cells in the body called antigen presenting cells, or APCs. So here's HLA in this cartoon. And in the case of an invader of a bacteria, virus, or fungus, for example, the HLA will bind parts of the proteins or even DNA from these invaders on the HLA. These are then communicate then with the T cells. And in the case of antigens from a microorganism, the idea is to clear the infection. And as I mentioned, ultimately also to develop antibodies. So should that foreign invader be encountered in the future, there will be some memory and that invader will be cleared as well. So as I mentioned in autoimmune diseases, if you think about celiac disease, type 1 diabetes, autoimmune thyroid disease, but this also extends to rheumatoid arthritis, lupus, multiple sclerosis, really the commonality, the theme here is that there are predisposing HLA molecules. So let's talk about how this may play a role in autoimmunity. So here again, we have our cartoon with the antigen presenting cell. And again, we have a particular HLA. But in this case, instead of it being a foreign molecule that has been processed within the cell and displayed on the HLA molecule, in this case, these antigens are things like gluten that has been changed and made more immunogenic or more responsive to the immune system, these gluten immunogenic peptides. It could also be parts of the thyroid follicle in the case of autoimmune thyroid disease, or in different components of type 1 diabetes, insulin, for example, but a number of other autoantigens. That's what these are called, autoantigens. And again, similar to a foreign invader, the HLA will present this to the immune system. And in this case, there is autoimmunity, meaning that antibodies are made, but also there is tissue destruction. And as we know in celiac disease, that occurs in the small intestine. But it's very complicated. And I, of course, don't have the time to go into all of the complications and intricacies of HLA and the different autoimmune diseases. Shown here is a table. On the right, you see all of these different autoimmune diseases listed. And then you can see in this case the effects of these HLA, specifically class 2 effects. And what makes this complicated is you not only have predisposing HLA factors, and what I'm going to be talking about particularly is celiac disease, but there's also been the observation of some protective HLA effects. And that plays a role in different autoimmune diseases, although not to the extent in celiac disease as in other autoimmune diseases. And so the focus of the rest of my talk will be on these particular HLA susceptibility factors in celiac disease. So in celiac disease, the two that we focus on are called HLA-DQ2 and HLA-DQ8. And so this is another cartoon that you've already seen presented by Dr. Jabri, but you can see essentially that you have these alpha-gliadin molecules that make their way from, these are derived from gluten, they make their way through the small intestinal lining. The lining is composed of these cells called enterocytes. When it gets here into what's called the lamina propria, there is a chemical reaction by tissue transglutaminase to make this gluten peptide, essentially this protein, more immunogenic. And that immunogenic antigen is then presented by DQ2 and or DQ8 to the immune system, specifically the CD4 T cell, which then mounts a gluten-specific abnormal CD4 T cell response. If we drill down a little bit more specifically to what makes up HLA in celiac disease, we first start with the genes. And these genes, the HLA genes, are all found on chromosome 6, and this is called the MHC region. And you have 3 different classes in this region, and we're focusing here on class 2. And that class 2 encodes for a number of genes that can be found on different, what are called loci, or different regions. So we have DR, DQ, and DP. And in the DQ locus, we have DQA1 or alpha 1 and DQ beta 1. And you need both of these essentially to encode for proteins that make up this HLA molecule that sits on the antigen presenting cells. And then you get the DQ alpha chain and the DQ beta chain. So this slide is not meant to go through in detail, but this shows you the complexity of HLA genetics in that you have a number of different configurations that can occur for both the alpha chain and the beta chain. And essentially, if we look here on the left, we have the different names for these configurations. So for example, DQ 2.5 refers to a beta chain that's made up of this configuration with an O2, O1 or O2, and an alpha chain, which is made up of O5, and that can be of the type O1, O3, O5. So these are all different kinds of genetic configurations, but they all encode for this type of DQ molecular 2.5. And a similar thing can be said about DQ8. There is another configuration called DQ 2.2. And then just a note about these other half heterodimers. Essentially, that means that you only make half of the DQ molecule, either DQ2 or DQ8. And whether or not those confer susceptibility is perhaps still a matter of some debate. So then let's look by risk. So if we know what the HLA makeup is of an individual, can we predict how likely it is that they will develop celiac disease? And so here I'm showing the risk as a 1 out of number. And I'm going from most risk to least risk. So here, if an individual has inherited only DQ2 and DQ8, so remember these are genetic factors, so they're inherited from both your mom and your dad. So if you only make DQ2 and DQ8 at this DQ locus, the risk has been estimated at 1 in 7 to develop celiac disease in that person's lifetime. DQ2 homozygous, and when we say homozygous, that means that the only HLA DQ molecules that are made are of the 2 variety, and that also confers a higher risk of 1 in 10. DQ8 homozygous, so again, an individual who only makes DQ8, about a 1 in 12. And then we get into actually the most common of the genetic susceptibility factors for celiac disease, specifically DQ2 heterozygous. So that means that there is one allele that's made up of this DQ2. There, the risk is about 1 in 35. DQ8, the heterozygotes are a slightly lower risk. And then we get into these somewhat, these half heterodimers. So if you have only the beta chain, again, a lower risk, just the alpha chain, an even lower risk. And that's nearing those who do not have any of these susceptibility factors at their DQ locus. What we've learned from studies like the TEDdy study, which you'll hear Dr. Ed Liu talk about later this afternoon, we've learned that HLA really in celiac disease plays a major role. So in fact, it appears to be a bigger risk factor than things like breastfeeding or infant introduction of gluten, for example, to children. So clearly you need to have genetics, and specifically DQ2 and or DQ8 for celiac disease to develop. But the important thing is that HLA is necessary, but in and of itself is not enough. It's not sufficient to develop celiac disease. So I like to remind patients when I talk to them about celiac genetics about this Venn diagram. So if we think about the DQ molecules that the whole population has, we see that HLA DQ2 and 8, especially in those of Northern European descent, for example, for DQ2, make up about 30 to 40% of the population, meaning that 1 in 3 walking around has one of these susceptibility factors. But in the whole population, celiac disease is only about is found at a prevalence of 1%. So again, you can see that having HLA DQ2 or DQ8 in and of itself is not enough to elicit disease. So we talked about in the last session some kind of perfect storm that sort of comes together to develop actual disease. So a few pearls and promises and pitfalls of celiac disease genetics in the clinic. So the way in which we currently use HLA genetic testing is for its negative predictive value. And what do I mean by that? I mean that if we test someone and they do not carry HLA DQ2 or DQ8 in their genetic testing, then we can say with nearly 100% security that they are unlikely to develop celiac disease in their lifetime. So that's 100% negative predictive value. And honestly, that can be very helpful for patients who either have already started a gluten-free diet and are interested in knowing whether they have celiac disease. If they don't have the genetics, we can pretty securely say that they don't have celiac disease, although they may have something else, such as gluten sensitivity. It can also be helpful for family members who are trying to determine who might be at risk and who might need to have screening in their lifetime. And so genetics can be very helpful in the clinical setting in those ways. Of course, if you carry the genetic susceptibility, it doesn't mean that celiac disease is present or that it will ever develop in someone's lifetime. Remember that 30 to 40% of the population carries those susceptibility genes. The other thing to note, and this is very important during a pandemic where we're not able to see patients as readily and get their blood, we can also do genetic testing with a simple saliva test that can be done at home. What are some promises of celiac disease genetic testing in the future? Well, of course, what we would like to be able to do is to intercept those who are at highest risk. So would there be ways to identify high-risk individuals and have a way in which we can stop disease from ever occurring? As we've learned from some of our clinical trials, some of the non-dietary therapies will be specific for certain HLA types, and so knowing someone's genetics will be important. And then finally, this idea of can we get a score from all of the genetic factors, that not just HLA, as well as environmental factors, to get some kind of a composite risk score that would tell us who might be at higher risk. And this is data from type 1 diabetes, where actually they're moving into this space where you can take a genetic risk score, body mass index, age, and then the presence of autoantibodies, and pretty precisely determine who is going to get diabetes. So perhaps this is the direction that all autoimmune diseases will be going in. Finally, some pitfalls. There is still a cost associated with genetic testing. Some people have asked me about implications for insurance, but this actually has never really come up as a major problem. I think importantly, there can be the issue of misinterpretation. So again, a negative test means that we can rule it out. A positive test does not mean that someone has celiac disease. We need to do additional testing, serology testing, biopsies to securely make the diagnosis. And then just finally, this direct-to-consumer testing often comes up. And can we use that to actually do genetic testing for celiac disease? Well, you may have heard of 23andMe. They use these things called single nucleotide variants, or SNPs, which are basically variation throughout the genome that makes all of us slightly different from each other. And they use these to tag the HLA allele. So it's not the way in which we do genetic testing for HLA typically, but these are ways in which it can be done, and you can mark these HLA alleles. And there are 6 SNPs that have high sensitivity and specificity for celiac disease. And so you can see the positive predictive value is very high in individuals of Northern European population. So I'm just showing the different SNPs that are included on the 23andMe. And so if they are present, you can say that you have tagged those HLA molecules. And again, I think though that since we're using it for its negative predictive value, if a patient doesn't carry these, it doesn't mean that they don't have the HLA. It just means perhaps that it wasn't tagged appropriately in that population. So hopefully I've shown you that HLA differentiates self from non-self. It plays a central role in autoimmunity. And finally, I hope you've gotten some pearls, promises, and pitfalls for celiac disease HLA susceptibility. Thank you very much.
Thank you, Sonia. Unfortunately, we miss the live audience applause that is so comforting for the speakers at the end of their fatigue, but I'm sure you would have gotten a big one. Thank you very much. So we now move on. We're going to have the discussion at the end of the session, as you know, for all the speakers. Now, it's my pleasure to also invite to the stage Dr. Peter Green, who, wait a second, I'm having a moment of...
Hi, Stefano.
I'll be with you. Hi, Peter.
Hi.
Peter is, of course, the director of the Celiac Center at Columbia University, and where he's, of course, full professor and well known in the world of celiac disease. He will talk to us about screening for celiac disease in autoimmune disorders. Your 20 minutes start now.
Thank you, Stefano. Also, thank you very much for inviting me, Banner, Ritu. It's nice to see my colleagues. I appreciate Sonia putting on those Australian birds. They're budgerigars, actually, that are misnamed in this country as lovebirds, but they are Australian. I'm sure everyone was interested in that. So what about screening for celiac disease in autoimmune disorders? Just need to advance. It's not.
Are you able to click the screen?
Yeah. So what is a screening test? So a screening test is done to detect potential health disorders or diseases in people who don't have any symptoms of the disease. The goal is early detection and lifestyle changes or surveillance to reduce the risk of disease or to detect it early enough to treat it most effectively. So with all of these, you've got to put celiac disease into context. This is a very important document that came out from the WHO, and it actually lists the screening criteria. And celiac disease does fulfill some of these. The disease to be screened has to be an important health problem. There's an accepted treatment for recognized disease, facilities for diagnosis and treatment. That's applicable to celiac disease in different regions of the world. Suitable latent and symptomatic stage, suitable test or examination, that the test is acceptable to the population, that the natural history of the condition is understood. Maybe that applies to celiac disease, but maybe not. There's an agreed on policy on whom to treat, cost of finding economically balanced with overall health, and case finding should be a continuous process. So you can see that celiac disease fits into some, but not all of these WHO screening criteria. I'm going to specifically deal with diabetes type 1, thyroid disease, and autoimmune liver disease. And some of these talks are obviously going to overlap, but with Joe's talk later on in this session and other talks later on. So this is data actually from Mayo Clinic, and it shows that in the red line, the patients compared to controls, that the years after diagnosis, there is an accumulation of autoimmune conditions greater than that in an individual who doesn't have celiac disease. And this is data from our clinic. And you can see that it's generally recognized in the population that about 3% of individuals have autoimmune diseases, and females have them in a ratio of 3 to 1. What's interesting, in celiac patients, about 30% of the individuals had at least one autoimmune disease, and this excludes dermatitis herpetiformis. But what's most interesting to me is that the female predominance is lost. And I think that this is something that has to be addressed, is why is there a more marked increase in the acquisition of autoimmune diseases in men? Certainly screening is a mode of presentation. So this is a group of children seen in the Celiac Center at Columbia University, the Children's Hospital in New York. And you can see the major modes of presentation for the diagnosis of celiac disease were recurrent abdominal pains, growth issues, which can be failure to thrive or stunted growth, and screening. And it actually occupies about a quarter of the patients that they were presented with their celiac disease. And while being a first-degree family member is one of those modes of being screened, autoimmune diseases provide a big group of those patients. And in children, it's mainly type 1 diabetes, and it was autoimmune thyroid disease. And then when you looked at the ages, it's interesting that growth issues were in all age groups, from the very young to those in adolescence. And screening was mainly in these older groups from age 2, because obviously the parent has to present the child to healthcare to have a diagnosis made. And interestingly, diarrhea in the orange box was only a mode of presentation in the very young. This is certainly a change in the modes of presentation. For adults, while diarrhea was the main mode of presentation, screening was 8%. And once again, it's family members and Down syndrome, but also screening autoimmune conditions. And amongst these people at this time, it was mainly type 1 diabetes, autoimmune liver disease, and Sjogren's syndrome. This is data from Joe Murray's work in the NHANES population, showing that over this last period in which it could be assessed in the NHANES, in the National Health and Nutrition Examination Survey, that in orange you can see an increase in the percentage of diagnosed celiac disease. And in the blue box, you have undiagnosed. And it's, to my mind, very hard to identify those undiagnosed people. And there is question, should we be diagnosing everyone with celiac disease? I think it's a very important issue. And there's a little bit of insight in this comes from our data in which we looked at the height of men compared to women, compared to the national standard, which is NHANES. And you can see in the top graph that men with celiac disease in blue were significantly shorter than the general population. This did not appear to apply for women, and there was a slight tendency for women to be taller. But this suggests that the men that were diagnosed in adulthood actually had the condition during their growth period, and their growth is less than optimal. So this is a byproduct of undiagnosed celiac disease. It's interesting that this finding of height was not found in a Swedish study. But to me, it points out that we need to diagnose celiac disease because at least this manifestation of people not reaching their optimal height is manifested. Now, how do we screen for celiac disease? Well, we use the antibody test that we use in diagnosis, and it's somewhat confusing as there's a spectrum of tests, the tissue transglutaminase, IgA, these gliadin peptides, IgA and IgG. In our studies in the diagnosis, the use of the deamidated gliadin peptide adds about 15% to the diagnosis. That is, people who have normal total IgAs and negative TTG, if you add those gliadin antibodies, you do increase the yield. TTG-IgG is a fairly useless test, while the EMA has high This TTG test is a good test, but no test in medicine is 100%. And the positive predictive value of how good the test is depends upon the population prevalence of the group being tested. So if you use this TTG, which has this excellent sensitivity and specificity, better than most of the antibody tests that we use in medicine, if the population prevalence is only 1%, that is in the general population, this test is going to have a positive predictive value of only 31%. But if you use it in a population that has a high prevalence of celiac disease, such as first-degree relatives or people with type 1 diabetes, the population, the positive predictive value is high and is extremely satisfactory, about 80%. But you've got to remember that these tests, they're affluent within the individual. And we do have this phenomenon of transient autoimmunity. And this is actually a patient who was under the care of myself and several others, that we demonstrated that while he continued to eat gluten, because he happened to own a bagel store, that he developed positive tissue transglutaminase, endomysial antibody, and deamidated gliadin peptide antibodies. And while continuing to eat gluten, these antibodies went away. And on 2 different occasions, he had a negative biopsy. He now would be called having potential celiac disease at the stage in which he had these antibodies, but down here, he just doesn't have celiac disease at all. And it was interesting to note in one of Joe's study, in which they looked at the serology findings of a community-based cohort, looking at 15,000 individuals at 2 different time points. You can see that there was a group that had negative serology at the start, and just a few went on to develop antibodies. But there was a group initially that had positive serologies, and then in the follow-up serologies, 27% of them lost their antibodies. So this is a major issue to my mind, that we've got to be so careful of labeling people with celiac disease based on one antibody test at one time. Interestingly, those that went on to develop celiac disease diagnosis, this 20% at the bottom, one of their characteristics was that they did have another autoimmune condition, such as hypothyroidism. Now, what about type 1 diabetes? Most of the studies show that there's increased rate of celiac disease, and it occurs in ranging from 2.5% to 16%. In several studies, celiac disease is more common in the youngest. In this one study mentioned here, it was 3 times more common when the diagnosis of celiac disease, when the diagnosis of diabetes was made at age less than 4 versus at the age greater than 9 years. So this strikes these very young kids frequently at the time of diagnosis. But screening guidelines vary. The American Diabetic Association, this International Society of Pediatric, Adolescent and Adolescent Diabetes, the Canadian Diabetes Association, NIH Consensus Conference, recommended screening of only symptomatic people with diabetes, compared to NASPGHAN that recommends screening of all those with diabetes, type 1. So we were interested in what was happening in real life. But before I get to that, this is another study showing that this was actually from India, and it just took 90 children with type 1 diabetes, and you can see this high rate of autoantibodies. 50%, these 2 on the top are antithyroid antibodies, very high rate, and 22% of this cohort had tissue transglutaminase antibodies. Interestingly, none had ovarian antibodies, and 2 had antibodies which would suggest the development of Addison's disease. So these antibodies are common for celiac disease, but more common for anti-thyroid antibodies. So as I mentioned, we were interested in what's happening in real life. So we sent out a questionnaire of, it was mainly to dietitians and diabetic caregivers. And the bulk of the responses were from the US and some from Canada, and 30% were from diabetes clinics. Interestingly, endocrine clinics and not the diabetes center were the most frequent to screen. But only 35% of the facilities for which these individuals work screened. 43% of them screened at diagnosis, but not all of them even recommended a biopsy. Of those that screened, approximately 20% screened annually, and others arbitrarily picked 6% biannually. So the guidelines are not all that clear and vary, and practice varies. I know in New York, certainly at our diabetes center at Columbia, they screen virtually every year for individuals with type 1 diabetes. So is it beneficial to patients with type 1 diabetes to receive this diagnosis of celiac disease? I think that's not clear. I've seen young individuals who, the families, the young child is diagnosed with diabetes and then they get another hit having celiac disease. And, you know, in my experience, the parents have said it's the celiac disease which is the hardest to manage. So it is a very great burden to receive this dual diagnosis. What about thyroid disease? This is a meta-analysis that we performed. And the prevalence of celiac disease in these 6,000 individuals was significantly increased. Interestingly, it was most increased in children and in hyperthyroidism. And in this study, we determined that 1 in 64 individuals with autoimmune thyroid disease had celiac disease. What about autoimmune liver diseases? In this systematic review and meta-analysis that we've completed, 1 in 30 individuals with autoimmune hepatitis had celiac disease. And the other autoimmune liver disease that has been associated with celiac disease is primary biliary cholangitis. And in this study of 1,500 patients, PBC was present in 1.7%. Now that compares to over 10% with thyroid disease, 8% with Sjogren's, and a lesser amount, 1.3% with IBD. So celiac disease occurs in a number of individuals with a variety of autoimmune conditions. We really need to be able to demonstrate that there's benefit to these individuals to be diagnosed with celiac disease. And I think we've got to be very careful. Those autoantibodies to TTG may disappear in an individual with diabetes. In fact, several studies show about 20% of them will disappear. So before we race in and give this double diagnosis, that we have to demonstrate is of value, especially these young individuals, we have to be very careful and there have to be more studies made. So thank you very much, Stefano. I think I may have made it just on time.
Yes, Peter, thank you very much. You have made it on time. Wonderful presentation, very clear, lots to discuss. I expect a discussion to be live. You already have some questions, Peter, so you may begin responding them, answering them in your Q&A button. Now we move to another esteemed good old friend, Joe Murray. Joe Murray is professor of medicine and consultant in the Division of Gastroenterology and the Department of Immunology at the Mayo Clinic in Rochester, Minnesota, and is of course the head of their celiac disease program. He will talk about something similar, autoimmune disorders in celiac disease. Joe, microphone is yours.
Thank you. It's indeed a pleasure to be here there with you all.
Remember to speak as loud and close to the microphone as possible, because the audio may not be perfect. Thank you.
Okay, great. Well, I'm going to talk to you about autoimmune disorders in celiac disease. And after that great introduction from Peter Green and Sonia to these topics, I'm going to focus a little bit more on the autoimmune disorders and their causal relationship with celiac disease. So I want to first start with a case, because of course, our work, I think for all of us who are clinician scientists, is driven by our experience with patients. And I often think the best lessons I've learned in my life or my career are those I've learned from patients. And this was a 25-year-old woman who presented with a skin rash and escalating abdominal pain over a 2-week period to her primary care doctor. No relevant family or personal history. She did experience weight loss relatively quickly. She developed this skin rash, which you can see was on the tips of her elbows, her knees, also on the palms of her hands, and it rapidly expanded somewhat over a matter of days. The patient was hospitalized because of increasing abdominal pain and generalized malaise. It was rapidly identified that this young lady was quite ill with anemia, neutrophilia, eosinophilia, an elevated CRP. Her albumin was quite low, hyponatremia, elevated liver function tests. A CT scan shown here with the arrows shows a thickened jejunum. A chest x-ray showed chest x-ray infiltrates. I should say, of course, at this stage, 2 COVID tests were negative. A bronchoscopy, because of now developing lung symptoms, showed hemorrhage into her airways. And an endoscopy showed a mildly inflamed jejunum, shown here. And histology demonstrated increased intraepithelial lymphocytes in the duodenum and some mild atrophy, but only in this jejunal segment. Her TTG IgA antibodies, deamiditoglide and IgA and IgG, were both positive, but the endomysial antibody was negative. She carried HLA-DQ2.5, as we just heard from Dr. Kupfer, is one of the major celiac-associated HLA types. And her skin biopsy showed both neutrophilic infiltration with some vasculitis, as well as some faint IgA deposits. And I'm going to come back to this story at the end. So we're going to talk about incidence of autoimmune disease and treated celiac disease. We've already heard a taste of that from Peter. We're going to talk about organ-specific autoimmune diseases that occur in the context of celiac disease: skin, lungs, nervous system, heart, liver, and blood. We're going to talk a little bit about the targets, or how those are targeted, and then to summarize what this means, I think, from a clinical perspective. So first, I want to talk about in little detail about the incidence of autoimmune disease in treated celiac disease. And as we know, there are large studies, and we've already heard from Peter, showing an increased risk for both thyroid disease and type 1 diabetes in treated celiac disease and that association. There's been little done on actual incidence of autoimmune disease in treated with patients. The data about the gluten-free diet is conflicting. And there's also this issue is, should treated patients with celiac disease be screened for autoimmune disorders? So I want to talk about a study that Imad Absa, my colleague in the pediatric celiac clinic here at Mayo, headed, which was a retrospective review of all of our incidence cases from Olmsted County. That's that little red county in the bottom left here, which is the county surrounding the Mayo Clinic. We have counted all health since 1966, and we even go back many years before that. And we've included all patients diagnosed with celiac disease, both adults and children. We abstracted their demographics, looked at the incidence rates, primarily of the 2 most identifiable autoimmune disorders, thyroid disease and type 1 diabetes. And this involved a relatively small group, but again, we're a small county, with 274 patients. The majority are female. Many patients had autoimmune disease diagnosed before their celiac diagnosis, and others after, with the 2 most common being by far type 1 diabetes and thyroid disease. And a much smaller proportion developed an autoimmune disease after a celiac diagnosis with an average follow-up of about 6 years. And the event rate was 4.8 per 1,000 person years of follow-up. And this is the slide you've already seen, showing that individuals with treated celiac disease were more likely to develop an autoimmune disorder. And what I want to break it down, though, is to break it up. It seemed like the children, shown here with the solid red line, seemed to get more autoimmune disorders than the adults. And similarly, individuals who had already had a prior autoimmune disease were more likely to get a subsequent autoimmune disease. Again, this is that genetic predisposition to autoimmunity that is so common in these patients. Looking at the types of autoimmunity, this is just a whole catalog of the autoimmune disorders. And we're not going to go through all of these, but apart from the thyroiditis and the type 1 diabetes, there are a smattering of other disorders that occur from time to time. So the conclusion that Imad and the team had was that autoimmune disorders, especially these two endocrine autoimmune disorders, occurred at a set rate that's not terribly low. This is accumulated over an average follow-up of almost 7 years. There was a higher incidence of these and an earlier development of autoimmunity in those who were diagnosed with celiac disease as children. And the suggestion is that we should at least monitor for autoimmune disorders in these in patients, especially children, for especially the autoimmune thyroid disorders. The second part of my talk is focused on celiac disease triggering autoimmunity. This is we have to address a little bit mechanism, the gluten triggering of diseases, and reversibility with a gluten-free diet. And usually I want there to be no identifiable alternative explanation, such as malnutrition or deficiencies. And the organ-specific autoimmunity we're going to address are things like dermatitis herpetiformis, the classic autoimmune manifestation. We'll talk a little bit about celiac disease in the liver. We'll talk about celiac disease in the lung, myocarditis, the nervous system. And those are all disorders where there's at least either been a significant number of cases or there is some data on frequency. But there are other things that occasionally pop up in celiac patients. It's not clear how many of them are actually reversible by a gluten-free diet, or whether they're simply chance occurrences in individuals who are also at risk. But dermatitis herpetiformis is the prototypical autoimmune manifestation of this disorder. Those not familiar with it it's an extremely itchy disorder affecting the extensor surfaces. It's symmetric. Most patients have no GI symptoms, though at least 3/4 have villus atrophy. It is gluten sensitive, and the mechanism had been the source of some uncertainty, but probably the studies by Sardi et al. In the early 2000s defined this and identified that patients with DH have a distinct antibody profile that targets tissue, or not tissue transglutaminase, but epidermal transglutaminase. And I took this one figure from their excellent paper in JXMed, which showed that when you absorbed the antibodies in the serum with epidermal transglutaminase in the DH patients, you reduced the antibody reactivity against epidermal transglutaminase. You did not affect the antibody reactivity in the celiac patients. And this was at relatively low dose. They had other elegant studies that suggested this. In our group, we looked at co-localization of tissue transglutaminase and IgA deposits in patients with dermatitis herpetiformis. And we did not find co-localization between the deposits of IgA and tissue transglutaminase in the skin. But when we looked at the co-localization of the IgA deposits, we found it co-localized with epidermal transglutaminase, shown here in this study, showing that the stippling that we get is a stippling that occurs because of co-localization with epidermal transglutaminase. So in these patients with DH, they usually have antibodies against transglutaminase, that's the tissue transglutaminase like celiac patients do, but they also have this distinct antibody profile that is now recognizing epidermal transglutaminase. There may be a similar mechanism for the recurring aphthous stomatitis that seems to be responsive to a gluten-free diet if it's identified. And that's part of that mucocutaneous side. The second condition, or the condition we considered in the patient I presented at the beginning, was this condition, Lane-Hamilton syndrome. It's the association of pulmonary hemosiderosis with celiac disease. Patients present with cough, hemoptysis, and anemia, and it can be totally reversible with a gluten-free diet. It's rare, and the target antigen really is unknown, but there is transaminases in the lung, which may present as a potential target. It is important to identify the celiac disease early to prevent permanent lung injury. The nervous system is really a talk on its own, and I really don't want to go into that in any great detail, but there have been a number of targets that have been identified. Transglutaminase 6 has been identified as something that's quite common in the nervous system, has a significant homology with tissue transglutaminase. There are also targets for the Purkinje cells in the cerebellum for patients with ataxia have been identified. The most common neurologic system disorder that's seen is peripheral disorders, distal axonal neuropathy, small fiber disease, mononeuritis multiplex, and then occasionally rarely cranial nerve disorders. Acute autoimmune deafness or retinopathy, for example, can sometimes be seen in celiac disease. And in these, anecdotally, they seem to be gluten dependent in that you can prevent or progression with a gluten-free diet if the celiac disease is identified promptly. Ataxia, dementia, movement disorders, seizure disorders, all have been seen in celiac disease, but a causal relationship of gluten is perhaps best recognized for ataxia. Cognitive decline has been the source of some work that suggests that identifying celiac disease might slow or arrest cognitive decline in people so affected. Reversibility, however, for the nervous system disorders is slow and uncertain. It is most common in the peripheral neuropathies and less common that you will see reversibility in the central nervous system disorders. But some of that is, I think, the consequence of the nervous system itself, especially the CNS, is not great at repairing itself. And finally, I make the clinical point, I would never contemplate a gluten challenge in patients who have a significant neurologic autoimmune disorder in a patient with potential celiac disease. So I do not challenge those patients. I want to now move to a different organ system and a different patient. This was a 23-year-old Caucasian male presented to primary care with 5-day history of left-sided chest pain, worse by lying supine, fatigued, dyspnea on exertion, and intermittent crampy abdominal pain was also present. Referred to the local emergency department. The EKG showed non-specific ST changes, elevated troponin levels, and a bedside echocardiography showed global hypokinesis with a frighteningly low ejection fraction of 25%. So for the non-medics in this, an ejection fraction is normally about 60% in a young male, and an ejection fraction of 25% is frighteningly low, indicating, and then the patient was transferred to our care. And further review of systems didn't identify any contacts or anything. This is pre-COVID. There was a history of non-bloody diarrhea going on for a number of months. No nocturnal awakening, no association with food. The patient remarkably was quite ill from a cardiac perspective with a very dilated heart and also mildly distended abdomen. The lab tests really demonstrated anemia consistent with iron deficiency anemia, mildly elevated liver transaminases, some elevated markers of inflammation, coagulopathy, and a non-specific positive anti-nuclear antibody. Underwent cardiac evaluation with a cardiac biopsy showing lymphocytic myocarditis. GI evaluation showed total IgA deficiency, TTG-IgG of greater than 100, deficiencies of A and D, and endoscopy shows changes of villus atrophy with biopsy that confirmed the changes of celiac disease. Now, this is the heart. So is the heart being targeted by celiac disease? And there's really limited data. There were a number of case reports that over the first several decades into the mid-2000s, patients presenting with a cardiomyopathy with proven celiac disease. There have been a number of systematic studies done since that time, an Italian study suggesting an increased rate of celiac disease in patients with a dilated cardiomyopathy, and also patients on the heart transplant list in Italy having a rate of anti-endomysial antibody compared to controls. What about celiac disease patients? There's a non-specific diagnosis of cardiomyopathy increased among celiac patients, but not really significant when the data was stratified. So, and then there's a large study, of course, this is from Jonas Ludvigson's famous national cohort, demonstrating that there really was a borderline increase rate in celiac patients compared to controls. But again, this is primarily those developing after the diagnosis of celiac disease. So what are the potential mechanisms by which the heart could be affected? There is this, these patients have lymphocytic myocarditis, they have anti-cardiac antibodies. Curiously, the DQ8 mice that we've worked with also develop cardiomyopathies. The female mice develop cardiomyopathy with TTG IgG antibodies. The male mice of that type do not get the cardiomyopathy, and they don't get the TTG IgG antibodies. There is increased intestinal permeability, could lead to systemic absorption of luminal antigens, LPS spike effect, like you might get with a multi-organ system failure in a shock circumstance, for example. And then could there be nutritional deficiencies? And this patient did not have thiamine deficiency or any risks for that that could lead to a dilated cardiomyopathy. That's usually a high output state rather than low output state, however. What about the effect of a gluten-free diet on their ejection fraction? And most studies suggest there can be a benefit for the gluten-free diet on the ejection fraction. Our patient was treated with a strict gluten-free diet with a follow-up endoscopy, with family screening, persistently elevated TTG IgG, which of course is quite common among our celiac IgA deficient patients, where that TTG IgG often persists, and it may reflect some true autoimmunity. Patient was treated, of course, for symptomatic heart disease, was worked up for a heart transplant, luckily avoided that with immunosuppression and anticoagulation, and even got an ICD placed. And ultimately, after 2 years of follow-up, he completely recovered his ejection fraction and went back to normal. And his TTG IgG eventually started to drop, but probably in part related to the immunosuppression. The next organ, of course, is the liver. And we've already heard from Peter about the associations with autoimmune liver diseases. But in acutely diagnosed celiac disease, there's often abnormal liver function tests. They're usually relatively mild, and they usually normalize on a gluten-free diet, though there can occasionally be severe hepatitis. Alberto Rubio Tapia, who's now at the Cleveland Clinic, and put together this, which was the notion of what are the ways that a gut disorder like celiac disease could cause liver injury. One of them being autoantibodies, because of course the liver is packed with transaminases. But there are other potential methods. And the term celiac hepatitis refers to this gluten-dependent liver injury that will resolve on a gluten-free diet. Usually they've raised transaminases with periportal inflammation if you happen to do a biopsy, and there should be the absence of other autoimmune liver disease. And it can occur in both adults and children. And here's a biopsy from a young woman who had quite marked transaminitis, presented with liver disease, what seemed to be acute hepatitis, and had celiac disease diagnosed concurrently. And Alberto put together this algorithm, and basically I would draw your attention to a couple of parts. Individuals presenting with transaminitis, if they're more than 5 times the upper limit of normal, we need to look for other causes of liver disease. Or if it's alkaline phosphatase that's greatly elevated, in the absence of bone disease or bone issues, it's not bone alkaline phosphatase, which of course could occur because of the osteomalacia. is also you need to investigate for the cholestatic liver diseases. So another area is hematology. Hyposplenism may be reversible in some individuals unless their spleen has shrunken to a tiny size. That leads to infection risk. There's autoimmune leukopenia and even thrombocytosis or thrombocytopenia, both of which may be reversible with a gluten-free diet. So in summary, autoimmunity is common in celiac disease. Celiac disease triggered autoimmunity is less common. There are some ideas about what the targets might be. Reversibility with a gluten-free diet is not universal, but early intervention is important. Prompt testing for celiac disease is needed, and additional therapies may be needed dependent on severity and the criticality of the organ that is affected. And there is some vigilance for autoimmune disorders are warranted in children and perhaps even screening in children with celiac disease. And I believe that autoimmune disorders that occur in well-treated celiac patients on a long-term gluten-free diet are unlikely to be gluten dependent or even perhaps triggered by the celiac disease. And I want to end with that first case, that case we started with, who presented with a skin rash and central abdominal pain. It turned out she was PR3 and C-ANCA positive, and she was diagnosed with GPA. This is a form of vasculitis. AK used to be called Wegener's. We don't mention that anymore. And celiac disease. And she responded to her gluten-free diet, prednisone and rituximab, which of course will lead to issues with follow-up because we can't follow up serology essentially in a patient who is going to be on maintenance rituximab. But I will end there with acknowledging our celiac team. Imad Apsa especially runs our pediatric celiac clinic. Alberto's now moved on to the Cleveland Clinic. Roxanne and Eric Marietta. All of my colleagues who see our patients with celiac disease, our GI fellows, especially Yuri Hanada, who worked on the myocarditis, and our pediatric GI research fellows, as well as our lab partners. Thank you so much.
Thank you very much, Joe. Very, very good, extensive and comprehensive. And so we now switch to another of my old friends, long-time friends, rather. Hi, Carol.
Hi.
Carol Semler, you have seen her already as she was moderating the session before this one. She's, of course, professor of medicine in the Department of Medicine, the Division of Gastroenterology, and in our Celiac Center, she's a director of the Adult Clinical Research. Her title today is Bone Disease in Celiac Disease. Please.
Thank you, Stefano. I have to get my talk up here. Oops. Okay. Hold it. Do you see me? No?
You need to share screen.
I am, but here I am. Okay. Let me go into the big mode. Okay, my talk is about bone disease and celiac disease. I have no conflicts of interest. And bone disease is common in celiac disease. In newly diagnosed patients, 40 to 60% have osteopenia. These are adult data, and 10 to 20% have osteoporosis. Rarely do we see osteomalacia and rickets in the US, although in underdeveloped countries, rickets is more common. And despite a gluten-free diet, bone mineral density remains low in patients with celiac disease, and fracture risk scores remain high when you compare them to healthy controls. Osteoporosis is actually more common in men than women if you measure the forearm and fracture risk. Trabecular bone, the spine, is the most common site, and bone density improves on a gluten-free diet in most patients. So what correlates with worse bone disease? Some of these correlates are celiac related. We know that early onset of celiac disease, a high TTG antibody level, and persistent villus atrophy are risks for worse disease. But there's other factors: menopausal state, a low body mass index, low calcium intake, or low vitamin D, as well as medications and other underlying diseases. The cause of bone disease is probably multifactorial. Certainly if you malabsorb calcium and vitamin D, one develops secondary hyperparathyroidism, which promotes bone breakdown. There are bowel inflammatory cytokines, in particular IL-1 beta, IL-2, IL-6, and TNF alpha that also are pro-inflammatory, promote bone breakdown. And then there's autoimmune disease. And here, this in the last 10 years has arisen as a possible cause in some patients based on the identification of an antibody to osteoprotegerin, which I'll speak to now. So osteoprotegerin turns out to be a member of the TNF receptor superfamily, and it acts as a decoy receptor to inhibit osteoclast differentiation and activation. So it's the bone protector, if you will. And how do we know this protein is important? Well, in mouse studies, if you knock it out, the mice get early onset severe osteoporosis, and if you overexpress this protein, they develop osteopetrosis, or too dense of bone. So I'm just going to review the metabolism of bone turnover here. So bone is metabolically active, particularly the trabecular bone, and it's the balance between formation and breakdown that allows us to keep healthy bone. And this balance is controlled by three cells: the osteocyte, the osteoclast, and the osteoblast. And the osteocyte, the main population of cells in the bone matrix are osteocytes, but they have these dendritic-like projections and that can communicate with the pre-cells of osteoclasts and osteoblasts. And under mechanical stress and systemic factors such as hormones or cytokines, these osteocytes start promoting the production of rankle, which is a ligand that binds to a receptor rank that's present on pre-osteoclasts, and it both stimulates differentiation and activation of these osteoclasts, which are like multinucleated phagocytes that come and sit down on bone and start resorbing it. And that process of resorption releases coupling factors that then stimulate the pre-osteoblast cells into becoming differentiated osteoblast and activated to then put bone down on the space that was just reabsorbed. And just within the last year, there's a paper out by Cawley who has identified the source of osteoprotegerin, which people used to think it came from B cells, and it may still, but this author showed that osteoblasts can actually release osteoprotegerin, and osteoprotegerin is a decoy molecule or receptor that then binds to rankle and completely shuts down osteoclast function. So the belief now is that the rankle rank osteoprotegerin axis is what is the main control of bone formation and breakdown. So the first osteoprotegerin autoantibody was reported in 2009 in a patient with celiac disease. This was a 40-year-old man. He had a non-traumatic fracture of his left clavicle, and he was ultimately found to have celiac disease. And on bone testing, he had severe osteoporosis with very high bone turnover markers. And his osteoporosis, unlike other celiacs, worsened on a gluten-free diet, but improved when they put him on zoledendronic acid, which is an inhibitor of osteoclastic bone resorption. So the authors of this paper were curious as to what was causing this high bone turnover, and they, as part of the evaluation, they identified osteoprotegerin neutralizing antibodies. And how they proved that these antibodies were actually functional was in an expression system in vitro, where they could show these antibodies actually blocked the inhibitory effect of OPG on rankle-induced activation of its receptor rank. And so their conclusion was that these antibodies were involved in the osteoporosis and causing the osteoporosis of this young man. So there have been a few other studies since that index case report out of the UK by Riches in 2009. And when they looked at 15 other celiacs, 30% actually produced these antibodies, but in the other 3, there was no correlation here with bone mineral density versus the index patient who had a correlation with both the turnover markers and density. The Italian study in 2012 found no celiacs made this antibody. And then in the United Kingdom in 2015, after there was development of the ELISA assay, which was a little maybe more reliable or readable, out of 71 patients with celiac disease, 7 had these osteoprotegerin antibodies compared to 1.4% of controls. And here again, these antibodies did correlate with bone mineral density. Now, these same studies were done in patients with rheumatoid arthritis and ankylosing spondylitis. And again, it was about a 10% prevalence of osteoprotegerin antibodies. So let's go on to the clinical presentation of bone disease. In most people, it's asymptomatic and found on bone mineral density studies. Some present with fractures, and bone pain without a fracture is rarer, can be found with osteomalacia, again, in children more than in adults. Laboratory findings, the common findings are normal serum calcium levels. So if you're going to look for bone disease, it's not going to be in the serum calcium level because our serum calcium level is very much defended and bone will be broken down to maintain a normal serum calcium level. However, patients often have a low 25 hydroxyvitamin D3 level. They sometimes, not all, have increased parathyroid hormone. Some have increased bone turnover markers, alkaline phosphatase and osteocalcin and urinary pyridinoline. And some have increased pro-inflammatory cytokines in their blood that I mentioned before. How do you assess fracture risk in patients with celiac disease? Because this is really what we're interested in preventing. The most common way is measuring the bone mineral density. And this is done by dual energy X-ray absorptiometry. And there's 2 scores. There's the T-score, which compares your patient to sex matched and the age of 30, which is when we reach peak bone mass. And the Z-score compares your patient to both sex and age-matched controls. And this score is important in younger people. Remember, there's 2 peaks of presentation of active celiac disease. It's at 2 years of age and in the young adult life. The T-score that's less than minus 2.5 is an indication of osteoporosis, and that correlates with risk fracture. So the more negative the test, the higher the risk fracture. The risk for fracture. But this doesn't pick up all of our celiacs with bone disease. So many have recognized that we need to look at something else. And so what's been developed over time is this fracture risk algorithm score, so-called FRAC score. And this is country specific. It incorporates your clinical risk factors with your bone density. So what's the biggest predictor of another fracture, a previous fracture? Age, previous fracture independent of bone density. Age, low BMI, underlying disease, and medications such as steroids. And this fracture risk algorithm score calculates the 10-year probability of osteoporotic fracture. And so osteoporosis is now defined really as fracture risk by any of these criteria. How about the management of bone disease in those with celiac disease? Well, I always stop and recognize that I'm dealing with young people. So the first step is to figure out if they're involved in high impact sports or if they're at a high risk for osteoporosis or fracture. And both men and women now are involved in high impact sports. Strict gluten-free diet. So this is just to start until we know more. It's not that they have to give it up for life, but we have to be cautious. Strict gluten-free diet, this improves volume, density, and thickness in trabecular bone. But remember, the bone density remains lower than in healthy controls despite a strict gluten-free diet. vitamin D and calcium supplements if levels are low, and weight-bearing exercise. And it's important not to give bisphosphonates to those with osteoporosis at least until the villi recover on a gluten-free diet and they can adequately absorb calcium in the diet. Now there's two questions. Do we screen for celiac disease in those with osteoporosis? This is controversial. As Peter showed you, the prevalence of if you just take a population of unselected patients who undergo bone density study, the prevalence of celiac disease is very low in those normal. In osteoporosis, it's 2%. And if you do a meta-analysis, the prevalence is about 1.6%. On modeling studies looking at whether it's cost effective to screen those for celiac disease to prevent fractures, there's really no cost savings in this. And so there is not universal screening is not recommended. And celiac disease screening, though, is recommended if the patient has clinical or biochemical evidence of malabsorption. What about the reverse question? Do we screen for bone disease in those with celiac disease? Do we do it in everyone? And here in the United States, based on a technical review and the British GI guidelines, there's recommendation for a bone density study to be done after 1 year on a gluten-free diet and then follow up 2 years or so or greater based on the knowledge that people with celiac disease have lower bone density. If you look at the European Society for Celiac Disease guidelines, it's a little more comprehensive. The European Society recommends calcium, phosphate, and vitamin D levels at the time of diagnosis. Bone density study in adults is recommended if at baseline the patient has malabsorption or other high risk factors. If it's not, and if other than that, you would do it not later than age 30 to 35 years of age. And then of course to monitor the bone density every 2 to 5 years. Calcium and vitamin D supplementation is recommended, particularly before considering bisphosphonate therapy in those with osteoporosis, so you don't trigger hypocalcemia. So in summary, osteopenia and osteoporosis are common. The cause is multifactorial, but may include true autoimmunity with osteoprotegerin antibodies. There may be other autoantibodies as well. Assessment for bone disease is warranted, certainly calcium and vitamin D levels, and bone density study at diagnosis if they have high risk factors or 1 year after a gluten-free diet. And it's important to know that bone mass improves in most on a gluten-free diet alone. This is like 80% of people, their bone gets better, but not maybe perfect back to normal. Supplements, if low, if you have a low vitamin D level or calcium, clearly supplements are warranted. And it's important to know that persistent villus atrophy is associated with increased fracture risk. So we have to get people at least on a strict enough diet so that they recover their villi to a normal pattern, and we limit or reduce the risk that they're going to have fractures in the future. Thank you.
Thank you, Carol. Thank you very much. This, I guess, concludes our session, except, of course, for the live part of the discussion. So I'd like to see all our panelists. All of them are here except Joe. Here is Joe as well. All right. So we are all ready to answer your questions. I've seen that you have answered already some in your Q&A direct questions. So if you want to expand on some, I think this is the time to do it. We'll go in the same order. So I'd like Sonia to address some of the questions that she thinks are of general interest and maybe expand on them if you wish.
Sure. So there was a question about that actually up to 5% of celiac patients don't necessarily carry the genes. I think this is too high. I think it's probably less than 1%. Some of these data may have been earlier when we had different ways of testing for doing this genetic analysis. And so they may actually have been missed, or these were individuals who had different configurations that were not as well typed. So I think in the modern era, it is very rare to find someone. Now, I would say the caveat is if you have a patient with GI symptoms, you need to work that up. And I have had very few, I can count on one hand, patients where they do not have DQ2 or 8 and have all the hallmarks of celiac disease, but that is incredibly rare. So I think 5% is too much. And then there was a question.
Can I speak to that as well, Sonia?
Sure.
It really depends so much on the interpretation of the results.
Yeah.
Some labs present the results, whether they're at risk or not at risk. Other labs just give a list of the alleles. And I've seen many patients in whom they've had an interpretation of these lists that's incorrect. So I think that's a very great variable. Also, the half DQ2 issue is misinterpreted usually.
Yeah, no, those are great points.
And in addition, it's not the case for Sonia's patients, of course, but in addition, there was a report by Bob Anderson in the past that in some cases, the diagnoses were actually wrong, where they went back and revisited. Some of the patients had autoimmune enteropathies, others had Crohn's disease. So I think to label as celiac somebody who is clearly negative for both alleles, it's really a stretch. All right, Sonia, I'm sure you had other questions.
Oh, there was just a question about whether there can be de novo DQ2 and 8, meaning that the parents did not have one or the other. Not that I know of. The caveat there is that you could have, because it's an alpha and a beta chain, you could have alpha from mom and beta from dad. So both would have only half, but an individual, the offspring would have both. So that's called a configuration in trans, so that can occur. So the bottom line is, I think if you're using genetics, you want to just type an individual. You don't want to just infer from the parents. Plus there's, sort of random which allele, which genes you got from which parents. So you're better off just testing an individual who's in your clinic in front of you. And maybe those were the main genetic questions, I think.
Okay. So we then move to Peter.
I answered many of the questions, actually. There was an interesting question, like why does the body turn on itself when gluten is presented? It's just a perchance phenomenon that somehow people are ingesting gluten and TTG is activated. They happen to have, for whatever reason, they happen to have the HLA. Something that was very interesting to me was the realization that all of us with celiac disease or not have these gliadin peptides traveling through our intestine all the time. We can recover these gliadin peptides in our urine. So the intestine is usually permeable. And the factors that are responsible for one person who has HLA getting celiac disease, not really known compared to others, all the others with appropriate HLA.
Plus there are, of course, 40 other genes that do contribute to the genetic cassette for celiac. So you need to have the whole constellation, I guess.
Can I ask a question on behalf of one of my patients? Since we have all these experts here, I have a patient who has celiac and a number and thyroid disease and developed very bad rosacea in her 40s. Do we know any connections between celiac and rosacea as an autoimmune manifestation?
Alopecia, you said?
Rosacea.
Oh,
a facial rash.
Rosacea, yeah. I don't. Maybe the other panelists do?
I think it's not in the list of associated conditions. It is common though.
Right. Peter, I'm sure you had more questions on
Yeah.
the.
What's this?
So I think there is a question by Riccardo Troncone on the testing or not testing. You know, what is the level of TTG that you would use if you use a level of TTG to proceed with a biopsy in a patient who has type 1 diabetes? I guess this goes also to Joe. Either one can answer. Actually, I'd like to hear both of your replies.
Yeah. Certainly, I think that people shouldn't run in and do biopsies without a period of observation and demonstration of consistently elevated antibody levels, unless there is another reason to do it based on clinical symptoms. And minor levels it's such a judgment. I'm sure Ricardo faces this dilemma more frequently than I do, that it's such a judgment whether you are less concerned with lower levels. Once again, if symptoms and levels and making sure that people have a follow-up blood test before going in and having a biopsy.
Joe, what's your opinion on
And
this?
so I agree with Peter. I think the levels that are close to the threshold are more likely to turn negative. Also, I would add in there, what is the diet that the patient is on? Are they already on a low gluten diet? And I see that more and more often, and that makes the serology less sensitive and harder to interpret. The presence of endomysial antibodies, which are different, if they're positive, I think it's a greater prediction of actual disease. So that's one of the especially in those patients with moderately elevated antibodies. But I think we should not rush in to make a definite diagnosis at the earliest stage in patients who are found by screening. And when we've looked at follow-up in terms of patients with screening, as Peter already alluded to in his talk, it's hard to find a signal in the first few years after screen detection. Now, that doesn't mean that it's an entirely safe circumstance. I mean, some patients with undiagnosed disease will have substantial consequences. But it's hard to tell. And of course, there may be protections from having undiagnosed celiac disease, especially in a part of the world where there's too many calories. And the dangers of overnutrition are almost as bad as undernutrition in some circumstances. So I think it's a complex question. I think we have to be careful about rushing in. Now, that also means then maybe we should think about when we should actually test. It's a lot easier to decide not to test than it is not to treat.
That's right. That's right. Once you have the information that there's villous atrophy, you can't not advise a gluten-free diet. So it's just so good to be able to restrain oneself from going ahead with the biopsy, I think.
I think, if I may, to complete this part of the discussion, it really is something that has to be judged on an individual case level, case by case, by an expert physician who knows these patients and the family who may have a desire to either skip the biopsy or on the opposite to get to the bottom of this. And when I say case by case, for instance, if there is already a family history of celiac disease, and the child with type 1 diabetes has positive TTG, then I probably would be more inclined to go ahead and try to make or disprove the diagnosis than otherwise. Okay, well, we leave it at here. Peter, other questions that you think would be relevant for general discussion before we move to Joe?
I think that I answered some of them. I may come back. I'll look through some of the responses.
Of course. No problem. Joe, your turn.
All right, well, we've got some excellent questions. One from a esteemed colleague, Peter Holt, mentioning that the response to a gluten-free diet is slow in these immune disorders associated with celiac disease. How long do you try it? Well, again, it depends on how severe the organ impacted is. So if it's heart failure, like our young patient, or a patient with severe lung issues, or I say very damaged liver, we're not going to wait to treat them with immunosuppression. The same would occur, I do that with the dementia patients, with patients with a severe cognitive decline. I will probably let our neuroimmunologist treat them aggressively from the get-go and not wait for the gluten-free diet to work. I don't give up on the gluten-free diet. I continue the patient on gluten-free diet, but I give up on it as the sole therapy. So I think that's a very important point. The severer the illness that people present with, I think the more aggressive we need to be in thinking of this as a disease that requires immune suppression early and hard. So that was one. Dr. Coltrella had a number of questions regarding the issues about duration of celiac disease, of untreated celiac disease, and autoimmune disorders. It's a very complicated issue. In children, I think there's more autoimmunity discovered after diagnosis of celiac disease, probably because they have a greater genetic risk for autoimmunity. So that's one. In the adults, there's often delayed diagnosis of celiac disease because people don't think of it, but the other disorders are tested and discovered. So I think we often find celiac disease after in that circumstance. And then, of course, there is the longer somebody has been diagnosed with an autoimmune disease, the older they are getting and the more medical opportunities they've had for testing. So there may be a loss of new cases. The incidence may die off after time. Of course, then you throw into the mix some of these genetic disorders, these polyendocrineopathies, and all bets are off when people get disease. I will see occasional celiac patients who have these multiple endocrinopathies who will develop type 1 diabetes in their 60s, even though they haven't had it before. And I suspect that's because of maybe not the air disorders that we heard of so eloquently this morning, but maybe something that's not that different. So it's a very complex issue. And then, other disorders. I think the other one is dermatitis epidemiformis, which I think is a very peculiar disorder. You can treat that with a gluten-free diet, and some patients, especially if they're diagnosed later in life, it will never get better, and they need to be suppressed. So we have to sometimes throw in the towel. I don't say throw in the towel of a gluten-free diet, but say a gluten-free diet is not enough on its own. Trying to think about any other.
I'll answer Jennifer's question. Hi, Jennifer. Have there been any studies on the rate of prevalence and rate of diagnosis, different racial groups in the US? We did a study looking at 500,000 different biopsies using a name algorithm that had been validated. And the ethnic group in the United States that had the highest rate of celiac disease were people from the Punjabi area in northern India. They had a 3-fold increase risk of celiac disease compared to average Americans. This was looking at villus atrophy in biopsy reports. There was very little celiac disease in people with East Asian and Southeast Asian. And it was interesting, Jewish people had the same rate as the average American. So I thought that was very interesting. There's a question. Yeah.
I just wanted to make a point on that. Since we're on the south side of Chicago here, we interestingly don't see and diagnose celiac disease in African Americans very frequently. And I think, Joe, your study has borne this out as well. Although interestingly, from the limited literature there is, you think that, well, maybe it's just HLA. There are differences in prevalence of HLA, and it may not be the case. In type 1 diabetes, that may not actually hold true. So there may be other factors in certain populations that are either increasing risk or being protective. So just an extra comment on the different populations.
Sure. And I think the African American is especially interesting in that they share the same DQ2 molecules, but they have different DR molecules. And we often think of HLA in isolation, but they're not in isolation. They occur as a part of a whole cassette or haplotype. And the African American DQ2.5 is different because its DR molecule is different. And so I think there may be the issue of protective DR molecule that occurs in that setting. So we have seen a little uptick when we looked at the US military a couple of years ago. We did start to see a few more patients who were considered in terms of African American who had celiac disease. So we may start to see that signal. And the other difference, of course, is the north-south difference. There's a latitude difference that individuals from the south have a lot less celiac disease than individuals from northern states. And that may apply even in other countries, not just in the US, but it's not universal.
But I think the point is too, you shouldn't use where someone, someone's ancestry in deciding to work someone up for celiac disease. I think, these are generalizations, but if a patient is presenting and you are suspecting it, you should still work them up for it, regardless of where they're from.
That's very true, Sonia. We actually demonstrated that Black people had a fewer rate of getting a duodenal biopsy.
Yeah.
So you're never going to diagnose it in someone if you don't ever do a biopsy.
Yes.
So I'd like to address the COVID question.
Peter, you addressed the COVID question. Let me interrupt you for a second. I address quickly a question that I see appearing here. Any downside for people occasionally cheating on the diet if they are asymptomatic? Please, people with celiac disease, do not cheat on the diet. Okay, that's it. Short answer. Now you go back to your COVID, and then we'll have the bone. We still need to hear from Carol.
Yes, there are a lot of questions for Carol. There are several studies that we've been involved in that it appears that people with celiac disease are not at increased risk of COVID, and also that they're not at increased risk of worse outcome. And there are a lot of studies, like international studies and studies based at Columbia and other centers. And it's not clear, or maybe a lot of people with celiac disease are actually taking extra precautions, but that doesn't really appear to be necessary.
I think just the other thing about COVID is a lot of my patients who I'm now doing televisits with say it's actually been really beneficial because they're at home cooking their own meals and actually find that it's been better than, so silver linings, obviously.
But also there are more IBS symptoms.
This may
Possibly. Carol,
Yes.
your questions on bone disease.
Okay. The first is, do we see a genetic connection between family members with significant osteoporosis and others with celiac disease, but not both in one person? So this gets difficult with bone disease. Clearly, you can have a genetic predisposition to osteoporosis and have celiac disease, but I don't know that when they looked at risk factors for bone disease and celiac disease, family history was not one of the factors that made patients at increased risk. So I think you can have other reasons to have osteoporosis other than celiac disease and the mechanisms I talked about. I don't know if anyone else wants to add to that. Then the next is, what are the recommendations for calcium supplementation? Because serum calcium is most often normal in patients with low bone density. Yes, that is true. The most important thing I think to get across is the epithelium of the intestine turns over every maybe 5 to 7 days. So if you were really, really strict on a diet and took out every shred of gluten out of your diet, if you were capable of doing that, your bowel would recover quite quickly. And in fact, we get nervous about biopsying patients if they self-start a gluten-free diet anywhere 1 to 3 months after starting a strict diet. So the important part is once the villi come back, then you're absorbing calcium from your diet normally and vitamin D. So the recommendation for the adult is 1,200 milligrams a day. So if you're someone who has a low level, then clearly you need to be taking some calcium, but it may be transient until you can get on a strict gluten-free diet. And just the caveat that vitamin D is a toxic vitamin. In other words, if you take these very high doses, 50, 100,000 units, several times a week, you could become toxic with that. So whoever puts you on these needs to monitor your disease and your progress if you have low levels. Was there anything else on bone? Anyone else want to comment on bone? Oh, do you recommend, I think this is L-dentronate drugs for osteoporosis and celiac disease. And there was another question about why wait for your villi to get better before you start treating with a bisphosphonate. And the answer is not, again, it's the devil's in the details. If you have bad osteoporosis and you don't improve your bone into a normal level. And do you have to wait a full year or not? I don't know. If you have a history of fractures, no. It's like what Dr. Murray said, if you've got some severe form of something, you need the gluten-free diet plus. But the plus, you have to be careful of any drug that blocks bone resorption, because if you cannot absorb your calcium well enough because your lining is flat in your intestine, you could trigger hypocalcemia, which is a severe life-threatening problem. So this has to be done carefully with people who understand what celiac disease is and the issues involved. So
maybe just on a related note, Carol, individuals who have celiac disease, active celiac disease, and have thyroid disease, they may find as their villi are healing that they're going to be absorbing the thyroid hormone.
yes.
And so need to be monitored very closely,
Right.
more closely for their thyroid levels. So just of note.
Right. So, I mean, in terms of bone, it really gets down to your bait. It's the FRAC score. It's not just celiac disease and that mechanism. It's what are your other risk factors? How negative and how bad is your osteoporosis? And then deciding whether you stick with a gluten-free diet alone, repeat the bone density in a year or two, and only if you have osteoporosis at that time, consider more therapy. But remember, I said the bone density doesn't tell all. If you have osteopenia and a history of fractures, you've got bad bones and you're at risk for more fractures. So this is, it's always the devil is in the clinical details of each individual patient.
There was a last question for you. Says, what if you already have been diagnosed with osteopenia, even though you have been on a strict gluten-free diet for 10 years?
Yeah. So that gets into the chicken and egg. So some people say you may have had celiac disease before you reached peak bone mass at age 30. You get diagnosed at 40, and now you have osteopenia. Does that mean you used to have a peak bone mass that was normal, or was your celiac disease not diagnosed for years and you never reached peak bone mass? And that's why even on a strict gluten-free diet, celiac patients tend to run lower bone densities than normal people. We don't exactly know why that is, whether they never formed good peak bone mass or whether they have some other factor related to celiac disease that just continues to not allow bone to come all the way back. So if you already have osteopenia, it's not getting better, then you go by fracture score, whether you decide on treatment. And fracture score is all of it. Remember, it's the FRAC score of all your risk factors, plus your bone density, or minus if you've already had a fracture, forget the bone density, you're at risk for another fracture. So this is changing. Our whole concept of osteoporosis is changing based on these fracture scores, as to not just calling osteoporosis a abnormal bone density study. It's all of these factors.
Okay, we are running.
It's also,
there is any burning point to be made? Yes, Joe. Joe, your image is frozen.
Oh, there's one thing on peds. I wish, Dr. Guandolini, this is for you.
What?
Should we be getting DEXA scan on peds patients? There you are.
Well, we actually had a panel that convened 3-4 years ago, trying to decide what test to do, what test not to do. In terms of the DEXA scan, the result was that we voted based on evidence, etc. And the result was that you don't need to do that unless there is a specific indication, like a history of fractures, etc. And the reason you don't is because even though some children may have some degree of osteopenia, in reality, they get back to the complete bone mineral density within no more than a year after beginning the diet, unlike adults. So we are lucky in this regard. I think Joe had to go, evidently.
Quick question. Can I address this one, Stefano? My daughter was diagnosed with celiac after a biopsy at age 9 in 2013. Very strict gluten-free lifestyle. Now her antibodies are negative. Is there a chance she was misdiagnosed? There's always a chance someone is misdiagnosed. If it was performed by a reliable person with villus atrophy and positive antibodies, there's no question about the diagnosis. But we do see people who are told they have celiac disease based on not accurate information. So if you have records that confirm that, you shouldn't question the diagnosis. Would you agree with that, Stefano?
Yes, I agree. I endorse that. All right, now this brings to the conclusion to our session. I want to first thank again Brooke and Duncan McLean and Karen and Eric Simon for supporting this session. And as a housekeeping remark, we now stop for lunch break. We reconvene for the session 3 at 1 p.m. Central Time. And the session will be dedicated specifically to celiac disease and type 1 diabetes. Thank you to all of my panelists and all who attended. Bye.
Thank you.
A queen